Very good. Well, welcome. I think we're going to get started. It's going to be 10:30 up to just around noon. I'm Lawrence Garcia out of New York City. My co-moderator is very well respected and known Horst Sievert out of Germany. We have a live case and some lectures under TEVAR and Peripheral. Our first case, we're going to start right now. I see them on screen from the Toyohashi Center, Dr. Takagi and Kinoshita. I believe that they are starting. If not, it's going to be Dr. Diaz there. We can see you. Can you hear us?
Yes.
Outstanding. Good morning and thank you. You want to describe your case for us?
Can I introduce myself and greet all audience? I'm Sho Takagi from Toyohashi Heart Center, Department of Cardiovascular Surgery in Japan. Today's second operator is Dr. Yoshihisa Kinoshita. We are so really happy today because we are so honored to receive this kind of opportunity to perform TEVAR live demonstration at TCTAP 2024 from our hospital. I'd like to express my gratitude for the chief of TCTAP 2024 and the other course directors. Thank you so much. 감사합니다. And I'd like to say thanks to all of the staff to support us today. Okay, let's start case presentation. Okay. Today's our case is simple TEVAR for descending thoracic sacral aneurysm using Nayuta thoracic stent graft made in Japan. Past medical history and previous endovascular treatment are as follows. Next slide, please. The patient is 82 years old man, and she had undergone EVAR using excluder with IVE for treatment of an abdominal aortic aneurysm in this February. The next slide shows operative CT findings. The CT shows 67 millimeter aortic arch aneurysm and descending sacral aneurysm, abdominal stent graft, and small left internal iliac aneurysm. Next slide. 3D CT shows aortic arch, descending sacral abdominal stent graft, and left small internal aneurysm. The descending sacral aneurysm looks like EG2 rupture status that required TEVAR. Okay. Today, our treatment strategy is to perform TEVAR using the Nayuta thoracic stent graft for descending sacral aneurysm. Aortic arch aneurysm is scheduled next to this TEVAR because of dangerous shape of the descending sacral aneurysm. And Japanese insurance system, 3 thoracic stent grafts can use at the same operation. Up to 2 thoracic stent grafts are possible. Next. I'd like to introduce the Nayuta thoracic stent graft. The Nayuta is a customized device comprising self-expandable G-stent and ePTFE, which was approved in 2013 in Japan. The PTFE graft is sutured onto a stainless metal skeleton. In other words, the Nayuta is endoskeleton device. Only two suture parts at the top and the bottom. Next. There are a lot of the types of the Nayuta depending on patient CT data. Fenestration applies only spec to aortic arch aneurysm. Next. In the process of preparing the Nayuta stent graft, the edited model was used for producing a physical plaster model in a 3D printer. A customized full-scale stent graft model was deployed to the plaster model before TEVAR. This slide shows history of the Nayuta. In 2013, the Nayuta approved and started business in Japan. And 2017, Nayuta got CE mark and started business in Italy. After that, the Nayuta spread Germany, Austria, and Switzerland. In this year, the Nayuta will start business in Spain. Okay, today's case is left common femoral approach, and the diameter of proximal landing zone is 25 to 31 millimeter, and distal landing zone is 26 millimeter. Today, we plan to perform TEVAR using the Nayuta with the dimension as follows. The rate of oversizing is 120% approximately, and the Nayuta deployed above celiac artery. Thank you.
May I ask a question to the history of this, or your procedure actually? We usually would start at the aortic arch and then go to the descending aorta and finally to the abdominal aorta. Is there a particular reason why you do it the other way around?
Okay, thank you so much. I think descending sacral is a danger shape. I think it is easy to rupture.
Yeah, so actually, in comparison with thoracic arch aneurysm, this sacral-shaped descending artery aneurysm is a little bit looks like risky for us, and actually the上は何ミリやったっけ？50ミリ？67。Yeah, so the next month, we will treat the aneurysm in the arch. But this time we discussed the heart team and the priority of the treatment is decided to the descending artery.
Okay.
Yeah.
So there's no concern that when you have the other prostheses in place, you have to go through them in order to reach the aortic arch, and they are not healed in at that time. In 4 weeks, they are still not really attached to the aortic wall. So that would be our concern, that we actually manipulate in the recently implanted prosthesis when we go to the aortic arch. But looks like you have good experience with that technique. Okay.
Mm-hmm. Okay, thank you.
So what you have done so far?
So we would like to show the Nayuta stent graft, which we will use today. This is a real one. カメラがこっち持っておいてこっち見える
I can see the patient is intubated. Is that your routine, that you do this under general anesthesia?
Yeah. So, ちょっとそれ見せてくれる So actually, Dr. Takagi explained that this is a plaster model of this patient, and actually in this plaster model we have already used the implant is a real Nayuta model like this. And also this one. This one is next month we will the model of the tracking arch, the Knight model for the tracking arch, and
So back to Horst's point, I guess one question. From the aortic arch, you're going to use a fenestrated graft, and
Yes.
so are you going to connect those two? In other words, will both grafts be in contact with each other?
間がちょっと上と下と
開かない。
開かない。Yeah, completely connected.
He got you. So
Yes.
I guess as your experience has been that you can do this kind of backwards, most would go proximal to distal from the arch, but you want to go the other way. And
Okay,
then
I will plan zone 0 landing TEVAR using fenestrated thoracic stent graft. Zone
Understood.
0. Yeah.
It's just it's going to be a challenge because the first one's not going to be terribly endothelialized by that point. And then if you're covering from stem to stern, can you just describe for the audience and also for my benefit what your concern is for spinal ischemia since you're going to be covering the distal diaphragmatic spinal arteries? What is your normal therapies here?
スパイナルコードの麻痺についてはどう考えてるかっていうので、全部結局長くなるから。
Spinal cord ischemia is an important issue in the TEVAR.
このケースはナイフと使うことによってなんかあれになるの？
Yeah, no.
なんかする？
For the purpose of preventing spinal cord ischemia, we have to avoid hypotension and hypovolemia, and
脊髄ドレナージとかするの上入れるとか。
Do you guys put a drain into the CSF on all of these people?
no, we can't do CF drainage.
That comes back to my question. So actually hypotension happens often during general anesthesia. So that's why one of the reasons why we never do general anesthesia. Is that your routine to intubate the patient for this procedure, or is it just because of the life case or any particular reason in this case? General anesthesia is the question.
Okay.
Okay.
説明OK。ちょっと説明するんでいい？これ。
そうですね。いい気がする。This is a net thoracic stent graft. We can choose the precurve from 4 types. この近づいて見える。Based on patient CT data, we can choose from
For shape of the tips.
Yeah.
Yeah. And this there is a 2-port. This one, so first we insert the infusion the saline from here, and at first we are filled with the saline in this column, and then after that we close these 2 valves and and continue to saline infuse the saline up to this one.
よく見れるか。This is neta tip.
Yeah.
Okay. This is flexible and short tip. And this side into the thoracic stent graft 23 French, and this part is 18 French.
Yeah, it's a structure is very, very simple, and it is easy to implant. Okay.
How did you prepare the groin? Are you using ProGlide or
Yes.
one or
this,
two?
Yeah, これプロガイドかけてるね。This in this time in this patient 24分20 24分24 French 何小さい
ドライシール。
dry seal 24 French dry seal already inserted, And of course, we we prepare the programmed system for the hemostat.
One or two?
Only one.
Only one.
Wow.
Okay.
Yeah.
While they get started, any questions from the panel? Anybody
sorry,
have a question?
24 dollar series cut down procedure.
Oh, it's okay.
How many French of the stent graft penetrated stent graft? How many French?
フェノストレートと
18, 20, 24?
Okay.
There-
表見して。
Their little placard they showed you was 21 to 22 French OD.
Okay.
ステネストレーティッドは何分なの
All of the Naita is from 21 to 23 French device.
で、上のフェネストレーティッドするやつは大きくなるから、ならない。
一緒です。
で、23、いや、でもこの回23フレンチですね。
23。
Yeah, in this patient, we use 23 French.
So just to make sure, you did the cut down or pro glide?
Cut down on this.
Cut down.
Left cut down, right
カット
is
ダウン、こっちはプログラムつけたの
プログラム。
あ、
A pro glide on the right side.
Yeah,
Right
yeah, yeah. Program is the right side. This side is a cut down.
Gotcha. And
Main
so,
focus of this procedure is alignment of penetrated area in the aortic arch. And as you see, is aortic arch is very tortuous. So it seems to be very difficult to align left subclavian artery to the penetrated zone. So another concern, my concern is modular leak through the penetrated zone.
Yep, actually, you are right. That actually, this shape of the aortic arch aneurysm is very complex. But as Dr. Takagi said, that we prepared the plaster model before the real procedure, and we try again and again to which model with which shape of the stent graft is better. And we always calculate and we always design the fenestrate part and the total shape of the aortic graft. And so until now, he had many experience of the fenestrated stent graft implantation, but we have no trouble.
And another important point is articulation between stainless frame. So the length of stainless frame is important, and the shown length, the strong point of shown length is very angulated stent graft. And the long length of frame is slightly rigid, straight, and characteristic is straight. Do you know what I mean? So it's,
Yeah.
And frame of stainless is very important, I think.
Okay. そうでステントの長さによってもうステントグラフが硬かったら伸びちゃうしっていうのが多分それはナイトはすごく柔らかいのでっていうことで言えばいいと思うんですけど、柔らかいよね。柔らかいです。Yeah, actually, this stent graft, as he said in his presentation, this the skeleton is very soft and very loose, and this graft is just only attached over the skeleton, just the upper side and the downside.
Yeah.
Only two parts are sutured, and it's very flexible.
Yeah.
Even this stent graft is a little bit longer, become longer. So we often use we often choose this stent graft for a little bit complex shape.
Yes, I understand.
Is it okay?
Frame is a jig and wave shape without the connection, each frame. Okay, I understand.
Okay, well, now we want to start we will begin the insert of the graft.
Which type of wire do you have in place?
This is a Landkist.
Landkist.
Landkist extra swift wire.
So does anybody think that this lady just has really bad aortopathy? I mean, she had an EVAR. Now, I thought this was going to be a pseudoaneurysm above the EVAR, but it looks like it's a whole separate expansion, and then she has a thoracic aneurysm. I mean, her aorta in general is just awful.
But there seems to be a quite healthy segment between the aortic arch aneurysm and the descending aneurysm. So, that's important because, as you mentioned, normally we would like to overlap the two grafts.
Exactly.
But when they start with the descending, then you have to think carefully how to place it because the aortic arch endograft may not reach the descending endograft, right?
And hopefully it will be obviously bigger, so it'll anchor, right? So, yeah. I was going to say that, you know, she almost has a type 3 arch, which makes it a bit better, right? Because it's the great vessels are away from you, but I think they're trying to land in zone 0, so eventually that's going to be a real challenging procedure. Does anybody who does on the panel tags or thoracic aneurysm grafts, do they routinely do CSF aspiration?
This patient have already TEVAR with doing a TEVAR. We worry about the spinal ischemia. So
Yeah.
we routinely spinal drainage.
Do you still quote a 1 to 3% chance of paralysis for patients?
Yes, especially this patient covered the Adam Kerr's area in the T12, T10 and T12 area is very massive it's a blood supply for
Exactly.
spinal
Yeah, no,
cord.
T12 is really the critical one. Horst, what do you think?
We always place the drain, but we never used it. So, fortunately enough, knock, knock.
Yeah, the one time you don't use it, though, is the time you need it, right?
Exactly. Yeah.
じゃあ上打つよ。いや、ここでいい。
And what do you, Horst, what do you guys quote the risk of spinal ischemia? Do you give them the highest number, or do you usually give them a lower number? What's your overall?
What do you mean with highest number of
It can be as high as 1% up to 3% if you look for spinal ischemia, but the general consensus is it's a lot lower than
It's
that.
a lot lower.
So
Yeah.
the question is, what do you quote to your patients?
Well, I tell them usually it's 1%, just to be on the safe side. But if they are concerned, then I say, okay, this is the highest number I can imagine. So I've actually seen only one patient in the last 20 years who had some kind of weakness which completely resolved after a couple of days. So it's almost probably lower than much lower than 1%. Yeah.
So we focus on the risk, but it doesn't translate to higher events.
Yeah.
So in this case, the most important point is for the positioning is the level of the lower side. We want to put the distance just above the celiac artery. So now he checked it. It's okay.
What is the blood pressure now?
Sorry?
The blood pressure? How is the blood pressure now?
Blood pressure now is 149 and 82. Okay, now let's release. 上からでもいいの？ここでいい。あ、
チェックでいいかな。患者さん近づけれる？そうすると。
So do you have a static image of kind of roadmap, or are you doing this by dead reckoning by the vertebral bodies?
Yes.
一番ないです。あれマップってできる？重なるマップとかってできないよね。これで。作れる？
So did you mark the aneurysm on the screen or in your brain?
Just a moment. On the screen でできるあれだオーバーラップみたいなオーバーレイみたいな。
動かしちゃったから。
もう一回打ってもね。Just a moment.
Okay.
このまま一緒でいいよね。
もしあるともう一回打てばいい。今出てる？どうしようんだ。でも場所移したんじゃない？もう一回取る？いい？これで出る？ Now we try to make a load map on the same screen.
But you have the catheter from above, so that must be easier.
Yeah, the pigtail is just north
ちょ
of
っ
you.
と年見せて。よし。ダメだね。Sorry, I cannot do that. But in this case, as you can see, the top of the dry seal is just the same level of the celiac artery. So that's a good landmark for us. Okay, let's do this.
So this deployment is a pin pull.
Yeah.
It looks that way, huh? Here it comes.
Now, covered seats, he's bringing down the covered seats like this.
It's pulling.
Looks like you're coming down, no?
It does.
You're almost in the sheath now.
For those who do this, does anybody do rapid pacing or anything for these types of cases, or is that never necessary?
No, never. We don't do that.
いいよ。はい、保存して。
ちょっと上見して。
So at this point, you still could move the device a little bit up and down, or not? The tip is captured, right?
いいよ、ドライシュ。ワイヤーのテンション。
Oh, it's coming down. Is the device connected to the delivery system? Looks like, huh?
It looks like they just pulled a stitch, and it looks like
Yeah.
these are the markers for the stitching.
ついてるように見えますね。
これどうしたら外れる？
Oops.
There, it released.
Okay, okay.
Thank you so much. よくいいね。
アウターシースもっとこう川島が入れたり。もっとこうこれ。
これ、あだ。
あげる？アウターシースを。
So as I understood, in this area, the stent struts are not connected to the fabric, correct? So they are sticking into the lumen somehow. Wow.
Oh yeah, look at it. It's deforming it.
You could post-dilate coming from the right groin.
Exactly, that's what I was going to ask.
The characteristic of this stent graft is gap between framework is so wide to maintain flexibility.
今持ってってます。
So it is a strong point and also weak
それ
point.
で引いたらどう？
To me, it seems a disadvantage. I mean, if these struts are sticking into the lumen, that's something, especially when it comes to the treatment of the aortic arch aneurysm. I would not like to have that.
これをあれする？バルーニングする？
バルーニングなし。
なしで。あ、そうか。いいんだね。外骨格だもんね。
It seems unusual that the push-pull doesn't allow the
Yeah.
sheath to come all the way back. You see how far?
Yeah.
That now makes it not even a triaxial system. It seems like it's a bit of a challenge to get that thing out.
先生、造影下からやりますか。
下からやる？
上からあれするの大変です。
Dr. Takagi, I have one question. Would you prefer implant the distal stent graft in advance, usually? Distal stent graft first?
Sorry, wait, just a moment.
Okay.
Does anybody know this device? Can somebody tell me what this loop is at the top? I thought that's what they pulled. I thought that was the stitching, but what is that at the top? It looks like it goes into the body of the stent, but then I don't see it continuing.
Yeah.
There's one line back here.
いや、多分竜に取られる。ちょっと入れた方がいい。入るんだったらね。入るんだったら入れた方がいいけど、入らんのだったら、まあそこでもいいかもしれない。
Initially, it looked to me that it is the connection between the delivery system and the stent, like with the Cook endografts, but
Yeah, like an anchor, right?
seems to be something different. Yeah.
外側。入った。オッケー。光の中まで入れて。いいよ。
下見える。
これでいい、それでいい。通ってるか。外は通ってない。いいか、オッケー、オッケー。フレームして。ちょっと入り口のとこまでリブテル持っていっといて、もうちょっと、もうちょっと、もうちょっと。オッケー、いいよ。で、抜いて。いいよ、よし。オッケー、マッチ。どこ行った？
Your access from the arm, is that brachial or radial?
Brachial. よし、じゃあ、OK、we check the angle. いい？
先生、コブのところですよ。
ここのところ、ここのところ。
全体で映らん。
もうちょっと下、もうちょっと上、もうちょっと上、もうちょっと上、もうちょっと上。
2回に分けてどれですか。
2回分けるか、上と下。上半分。じゃあそこから。はい。じゃあもう一回 DSA。はい。
じゃあ呼吸オープン。折れてます。あ、ダメです。
It looks to me that the aneurysm is still filling, right?
Yep. 下見るよ。
Still be a type 1A, right?
Yes. Type 1A.
Source from above.
じゃあ呼吸オープン。
で、これどうする？
バルーンしますか。
じゃあバルーンくださいな。Okay, as you said, we can see the type A and rig. So now we.
Okay. Sorry. This is no Android.
Oh, really?
Yeah. The Narita graft is middle part of is not sutured, so the Narita spread by receiving the blood flow. So it is the graft expanded.
So you mean that this skeleton is the inside of the graft,
Yeah.
and now the graft is a little bit shrinked. But
Yeah.
after the keeping the blood pressure, this stent graft is expanded fully.
最初のとこ
Are
ろ
you doing post-dilatation?
No. これもう一回取る？あ、なるほど。Yes, so as you can see, this is the original shape of the sakura annuals. And 最後見せてくれる？
So there's no post dilatation of this stent?
Yes, yes, yes.
Yes, there will be, or yes, there won't be.
So we won't perform the additional ballooning. Actually, this is so now as you can see the animal part you can see is a little bit irregular, but this is completely covers the graft outside of the stent, outside of the skeleton.
Yeah, but it looks like that the contrast is actually obviously coming from above and it's floating around the proximal part of the endograft. So at least what I see here.
It would still be considered a type 1A
Yeah.
endoleak.
1A.
No, actually, this in this case, the first stent is in the a little bit the inside of the annulus, the enlarged out, but the second skeleton is completely attached in the neck of the between the first aneurysm and the second aneurysm. So in this case, as I said at first of the presentation, he will do the he will repair the first aneurysm in the next month. But in this session, the sacral aneurysm completely covers the stent graft outside of this skeleton.
So how does it come that the aneurysm is still filling?
No. So the not filling. Actually,
So you are saying that the fabric is...
This is a real Naruto model, and now this stent graft is a little bit expand with by the
receiving the blood flow.
blood flow. So and in comparison with the first image.
I see.
So you are saying the fabric is expanding whereas the stent frame is staying in place? I can understand that.
Yeah.
But how can you
Yeah,
differentiate it?
as you can see, this is the original shape. Yeah, and final one.
So is there a way to confirm that, what you say? Is there using IVOS or CT on the table or whatsoever? You mean?
And this is a final image, final angle. That this maybe you thought that this is a little bit remain the stain of the animals, but as you can see, now the stent graft is completely covers the annulus. Just a skeleton, just a skeleton, the inside of the annulus.
Okay. So, it's probably difficult to confirm, but I understand what you mean. Can you comment again on the position of the stent strut, which is basically going into the lumen of the aorta? So that is strut number 1, 2, 3 from below. Is that something you are concerned about? I know it's not covered, but you have kind of metal frame which is obstructing 50% of the lumen. And especially when it comes to the treatment of the aortic arch aneurysm? No?
As you guys get ready, are we ready for case 2?
So, yeah, sorry, once again, I want to explain that. Now, sorry, this is a knife stent graft. Now, so this outer stent graft is inside of the skeleton. This stent graft is outside or completely outside of the skeleton. So as you can see, the final angiogram, so you look that a little bit stained outside of skeleton. The aneurysm stained just outside of the skeleton. But actually, in this case, the stent graft is like a extend like this. So so this extended part it looks like a remaining stain in this case, but in this region completely covered the disc graft.
Okay.
Thank you. It's a very interesting case because I think it does bring up a lot of suggesting some critical decision points in this case. If this is your concluding picture, do you want to summarize your case? Because we need to go to the second room and for the second case.
Yes. Summary. Yeah, actually that is all. Now we want to close the humeral part, and so could you move to the next room? Dr. Hirano waiting you.
Very good. Thank you for a very interesting case.
Thank you for your cooperation.
If we can go to room 2, Hirano Sensei.
Hi.
Hey, it's
Can you
Lawrence
hear me?
Garcia. Yes, we can hear you and we can see you
Okay.
fine. Lawrence Garcia with Horst Sievert in a very good panel. If you want to describe your case, that'd be fantastic.
Okay. First, I'd like to introduce myself, and I'm Keisuke Hirano from Toyohashi Center, and I'm so really happy now because I'm so honored to receive this kind of opportunity, live case demonstration at TCTAP 2024. So I'd like to express my gratitude for Dr. Takahiko Suzuki and Dr. Kinoshita, my boss in this hospital, and TCTAP's Peripheral Cost Directors. Thank you so much. And let me say thank to this case's attending doctor and this cathedral staff, all of the staff in this cathedral to support me today. Thank you very much. So let's get started. Please start the case presentation, Dr. Omori.
Okay, this case is intermediate claudication on the right leg, Rutherford 3, caused by right SFA CTO. The patient is 84 years old female with CRF on HD. The right ABI is 0.7, and final angiography finding is right SFA CTO and popliteal artery 90% and ATA CTO. The strategy, the target region is right SFA CTO. The strategy is EVAS guiding wiring and DCB or DS. This is an angiograph. Right SFA CTO. And popliteal is 90% and ATA is CTO. The lesion length is 225 millimeter. There are some classification. The technique point is 1, EVAS guided intra-plug wiring, and 2, how to use the EVAS supporting robot. Thank you.
We went from tag to a leg. So any thoughts on the leg?
Okay, please give me the
Do you
wire.
know how old this occlusion is?
And
Do you know how old this occlusion is? How long ago the symptoms
long?
occurred? Yeah.
どれぐらいだろう How long?
I mean, since how many weeks or
Regular?
months?
違う。年。
I mean not. I do not mean the length of the lesion. I mean how long ago
Yes,
the
yes,
symptoms
yes. I see.
occurred.
Yeah,
I see.
what's the duration of the occlusion?
Yeah. Now about 2 years.
2 years.
2 years.
Yes.
Okay.
Do you think
Okay.
that the CTO itself is not really the problem, right? I mean, it's the rest of that popliteal is awful. You're running all the way through the joint space if you're going to dilate.
Okay.
Shouldn't be a problem
like
to
to
dilate the popliteal at the end.
Introduce my procedure. Can I?
Yes, please.
Okay. Today's case is just superficial side of the SFA or the distal part of the SFA, very long CTO lesion. And so I selected the ipsilateral approach, and I used the 6-range catheter to make a strong backup. And I choose the very stiff wire, cross lead wire. And this wire newly released in this year by Asahi Intech. And can you see the tip? This is tapered wire. The tip load is 60 gram.
So what is the name of this wire again?
Cross lead
Penetration.
penetration.
And what is the taper down to? It's a 014 wire on the front end. What's the front end of that thing?
0.14 to 0.9?
0.09.
11. 0.11.
0.11.
Yes. In this procedure, I always use the stiff wire because I'm not afraid to use this. Because in the EVA Sky, it is easy to detect the wire in the vessel or not. So I'm always choose the stiff wire. And I use the 018 OTW balloon instead of the microcaster. And じゃあこれを
And you said ipsilateral approach? That means you are
Yes,
puncturing
ipsilateral
antegrade?
approach, antegrade approach.
Okay.
And I forgot the important thing. I'd like to introduce my special assistant. Can you see this?
Uh-huh.
Yes. This
He's doing the job for you, right?
Yes, EVA supporting robot.
Yeah.
We named Watson because the Watson is the excellent assistant of the Sherlock Holmes, so we named. And this robot obtained the government approval on September 2021, and we started to use the clinical use from October 2022.
What does it cost?
The cost. Cost is.
Is the robot getting more money than you or less?
Yeah, that's a problem. But this cost about $16,000. $16,220 million won.
Say again.
Yes,
Say
yes,
again. I could not hear that. How many? what is it?
$16,000.
$16,000.
Yes, 220 million won. Yes, but we try to.
No, that is the cost of the robot? $16,000? No.
Yes, it's a little bit.
But that's cheap. That's a bargain, no? Or is it per case?
2500万なので 16,000
How many series?
2500万円
Let's continue.
Let's continue on this one because this is going to be a hard case
じゃあ
for the time.
I'd like to show you the EVA Sky image, EVA's image. EVA's image に切り替えてもらっていいですか
Yep.
EVA's image を大きくし okay.
We can see the
Can you
items,
see
yes.
the, okay. The black part is the CDO and the white line is the wire.
That's nice.
And in this procedure, it is easy to get the angioplasty wiring. And because we always, during the procedure, at the long axial view, and sometimes we check the wire position at the short axial view. I'll show you. ここで切り替えられますか？$116.
$116,000.
$116,000. Okay. いいよ。じゃあ I'll show you the short actual view.
So you are just watching and the robot is doing the job.
Okay.
Okay.
Can you see?
Yeah.
Can you see? Yes. じゃあ go to the previous image. Okay. Can you see the image? This
yes.
Yes, this procedure is very easy to robot, but very difficult for the technician, human. That is a feature of one of this robot, I think. Okay, so go ahead. And most of the features of this robot, anyone can detect the high quality image if the technician have no experience. Is no problem to make the high quality image.
Gotcha.
Okay. Yes.
I think my kids would be better at that than I would in regards to the controller. My kids would be better at the controller just because.
Yeah. I'll show you the controller. So, this is the controller.
Yeah,
Like a PlayStation 2.
exactly.
Yeah, and so it is very easy. You don't necessarily require to understand the buttons mean, because if the images play straight out of the root.
So please explain, are you showing us a recording of the recanalization, or is the robot doing this alone without your help?
The technician
Are you asking if it's live? Yeah.
I don't know.
I want to ask, during the procedure, who control the wire? You control
Yeah.
machine?
The robot
True.
I could control myself.
And robot too?
Yes.
Wow.
So the robot is
procedure?
doing this alone without your support? Correct or not?
Correct.
Okay. So you don't have to be in the hospital when the robot is doing it?
No. So I can control the robot by myself and
Should have come to our meeting here.
do the wiring. In the future, I'll try to do it, yes. じゃあ、箸ちょっと動かしてみてくれる？ Okay.
So the panel is
If the
just
image
like a,
straight out from the root,
So your monthly salary will go down then, right?
okay. ちょっと外れてるね。Freeze.
yeah? So because you control the wire by yourself, so
Yeah.
can you show us how to control your Nintendo to guide
Nintendo, okay.
to move the wire?
I'll show. I'll show. じゃあ、by myself. By myself. Yes. Now, my special technician, Hashimoto-kun, controls the Nintendo.
I think
So this is the wire and the microcatheter, or just the wire?
I not use the microcatheter. I'm only use the 018 OTW balloon instead of the microcatheter. Yes.
But the robot is who's controlling this wire right now, not you?
What?
Who's controlling the wire? Is that you or is that the robot?
No. Me.
You.
I control the
Gotcha.
wire. But in the future, I'd like to make the full automatic robot. Yeah.
So then I missed something. So what is the robot doing if you have control about the wire?
Just do the ultrasound, right?
Is it the EVIS that it's controlling?
Yes, the robot. Okay. Nice.
What wire are you using to cross, by the way? What's the name of that thing again?
Cross read wire. 60-gram tapered wire. I think this wire is the wire's penetration force and is the strongest, I think.
So again, what is the robot doing? I misunderstood that. So
What is the robot doing?
Yeah, you are controlling the wire. So what is the robot doing?
What is the robot?
Yeah. You paid a lot of money for it, so it.
Just to hold the images.
Yes. The robot detects the CTO. Okay.
Yeah, I think we can also have somebody else to do the ultrasound, find an assistant. But I think this machine still have its advantage since a very steady state of the machine to do the ultrasound, but it's more expensive. I think the invention is step by step. Maybe step one is echo guide, and maybe the second one is wire control. Then all of us will lose the job, right?
Right. It takes the fun out of human interaction, talking to your echo tech or your ultrasound tech. There's at least some interaction there. But this is fascinating to me.
Actually, sonographer had a very difficult to hold the imagings during the procedure.
Yeah.
So that was Hirano's idea for holding the imaging during the hardwire penetrations.
Yes.
Yeah, but for that you don't need a robot. You just have a metallic arm which is fixed there, and you can move the transducer with your hand.
So Dr. Hirano, so I'm Dr. Ahn
Okay.
from Severance Hospital. So nice
Yeah.
to meet you again. So, how about the success rate compared to the previous the sonographer some guided procedure?
Success rate
Yeah.
compared, just same.
Just same.
Yes.
But
The
the
success
time was
rate-
different.
The
Procedural time.
No, not different.
Not different.
Yes, we compare the human versus robot, but the procedure time is not different.
So actually, his success rate is over the 95%. Over a long CTO. Yeah.
And the whole point of this is to say luminal.
Yeah.
All the trials that went before it never used this, and on average for a 10-centimeter lesion, which has been the average for these pivotal trials, 30% were CTO. So the 30% CTO rate didn't translate to a decline in the patency or the efficacy of the device. So I understand it opens up a whole world of atherectomy and so forth that you can do within the lumen, but does it improve patency rates from the Japanese data here?
Actually, their data shows over the 19% of forced lumen penetration can make some progression or some poor outcome after superficial femoral artery CTO. So they needed the whole segment penetration by the true lumen wiring. So that was their idea for the EVOS guided procedure.
I think the opposite is also true, right? How many times have we gone through a subintimal plane and it shuts down, and then you go through a different plane and now you can't get back to the same stent because you're in the true lumen as opposed to the false lumen, which has been the challenge before.
And even if the region around the pop region, their position was can make penetration to the distal, so very distal SFA lesion. So that was a very good idea for some the showroom and wiring over long segments.
Yeah. I find that to be really the place, you know, when you do a popliteal, it's harder because it's behind, but if you can do the true popliteal into a tibial, that to me has been one of the challenges of long CTOs in that popliteal segment, to enter true and exit true, which is really the challenge in a tibial circulation.
And we do usually bidirectional approach to the long CTO segment, and if the trained or the EVOS guided, their procedural time was not different from the bidirectional approaches.
Yeah.
So in an era you don't have EVAS, so you can really find a sonographer to do the job for you, because it's so time consuming, and he will feel so boring and eat the most of the radiation by the sonographer.
Yeah.
Okay.
So Dr. Hirano, where the position of a wire?
The distal part of the SFA.
Yeah.
Looks like a 100-meter long lesion when I look at the ultrasound images here.
Yeah. But the distal part of the SFA is the weak point for the robot, because the robot arm can only tilt up to 0 degrees. And okay.
So is this machine already available on market in Korea, or?
Yeah.
Already? Please ask. Asahi Intake. 韓国で買えますか？韓国でロボット買えますか？まだ。He said not yet. Yes.
With the emphasis on yet. Gotcha. So are you, you must have cleared 22 centimeters. Are you close to the exit of this CTO, or is that not?
No, it's an endless loop.
Yes.
It's an endless loop.
This is the. これ違うね。もうちょっと手前とワイヤーを見せてもらっていいですか。And the distal part of the SFA is a weak point for the, I said, and the probe cannot be applied from the back side of the knee, and the robot arm can only tilt up to 0 degrees, so this part is very difficult to detect the image for the robot. Okay. Yes. どう？ Okay. I think the wire pass color. I'd like to check the. もっとこっちですね。左下。もうちょい左です。じゃあ、もうちょっとこっち側に持ってきてくれる？ Okay, this is the distal part, and the wire passed the lesion. Yeah. I think this time is very short. To comparison the angiography guide for vascular treatment. So next, I'll try to check by the IVAS. Okay. じゃあロボットを一回下げてもらって、 ワイヤーパスタイムってどれぐらいだろう、30 minutes, 20 minutes. The wire passage time, about only 20 minutes for this one CTO case.
Yeah.
Okay.
But importantly, no contrast, and more importantly, no radiation.
Yes, I think so. This procedure is less invasive for the patient and us. Yeah. じゃあ
You know, because for a leg, the air kerma exposure to the patient, it's very, very low. But
Thank you very much.
to
Okay,
the
じゃあ
physicians and the support staff, it's still the same. Still scatters the same.
通っててほしいね。通ってると思うんだけど。よいしょ。
So I mean, the images are so good. Why not continue to use the ultrasound now for the rest of the procedure?
Because the wire already passed, so we changed the stiff wire to the soft wire, and I like to check the wire root.
Yeah, but that's something you could also do under ultrasound guidance, couldn't you?
Yeah, the point Dr. Sievert or Professor Sievert's making is that at this point you could do everything with just the robot. You put the
Okay,
balloon
yes,
in, you
yes.
put even a stent in,
ちょっと
Yeah.
because now you know the reference
JP,
vessel.
please hold the guide gesture.
While he's doing this, anybody on the panel not want to stent the CTO? Is there anybody who would just do the DCB here?
Oh, we never stent. Almost
上
never.
にして上を
Almost never now. Anybody else? Does anybody stent? I always look at it as, you know, how difficult was it to cross? If it was a real difficult crossing, then I'd probably place a stent in there.
通ってるらしい本当に。エコーで当ててみてくれる？
That doesn't look nice, huh?
通ってるね。Okay, so please.
This is the microcatheter, or
No, no, no. This is the
The balloon?
OTW balloon. Yes, I always use the O18 OTW balloon instead of the microcaster.
why
Because
such a
the
short
SFA
balloon?
Oh, it is. Its profile is small and easily to push than the long balloon. So I always use the short balloon. Okay. じゃあちょっと足このディスタルパートを通ってるかどうか見てくれる？はい。で、通ってたらちょっとソフトワイヤーに変えましょうか。
That looks like extravascular. Huh?
Yeah, I'll check. I'd like to check by the
Yeah.
ultrasound.
It's not acting. It's not acting very free downstream.
Yeah.
We have about 10 minutes left in this case, and we have 2
Minutes,
lectures.
okay.
Oh, there it is going out. You see that?
Dr. Hirano, I have a question
Yes.
to you. If there is some total occlusion from the SFA to
What to stop?
pulmonary artery, in
a
case
side-
of the pulmonary CT regions,
Maybe side brown.
is the robot-assisted EBUS is available or not?
入ってる。Okay. はい、入ってるね。Can you see the wire in the vessel?
Yeah.
Yes. It's not extra vessel, so I'd like to balloon this along here. ちょっと、じゃあバルーニングしよう。上にしてもらっていいですか？
Hirano, can you understand my questions? Hirano?
Okay.
Please.
Yes.
Yes, I have a question to you. If there is total occlusion from the SFA to the pulmonary artery,
Yeah.
is it available using the robotic-assisted EBUS for the pulmonary CT regions?
Yes.
Is it available? Okay, see.
Available.
Thank you.
Okay. じゃあ、please go up to 10.
2、4、8、8、10。
Okay. Go down. Okay, go up to 10.
2, 4, 6.
So I'm Kevin from
Okay.
Taiwan. So,
Go down.
so it's EVA's machine now is only available in
Go up to 10.
Japan. So only so commercially it is made in Japan. So right?
It's all already to use in Japan, available
What-
to use. Yes. Go down.
So do you have any
In
plans
Japan,
to
yes.
sell it worldwide? Maybe Taiwan.
Maybe Taiwan? Yeah. じゃあ、6, 8, 10. 後藤さん、山田さん。OK、じゃあ、台湾が欲しいって。
So would an alternative be just to take like a 40 by 200 balloon to start as opposed to
10.
this 4 by 40?
Yes, first I use this 40 balloon instead of the microcatheter, so I like to ballooning first. Okay, go down. And next, I like to use the wrong high pressure balloon. Okay.
Yeah, we always use long balloons, so
Yes.
never short ones.
Okay, different. But the short balloon profile is more smaller than the
Why?
long balloon, so
Have you seen this device called the transit device? It from Transit Medical. It's what's it called? It's the X something, but it's a nitinol cage. It goes over any balloon, so you can go in there and it's a long sheath, so you can use it for short recalcitrants or long lesions. And as you inflate, it tends to open up, so it scores the entire artery.
Yeah.
It's kind of a cool system, interesting system, but it's meant purely for delivery of drug when you're ready to put your balloon in for DCB.
I don't like the wire movement. It seems to be extravascular.
okay.
Yeah, it looks like the artery's left here.
Yes.
It's
yes,
extravascular, yeah.
yes.
You see the isn't there calcium? No, that's a side branch or extravascular.
It's a side branch, I think, yeah.
持ってて、20のディスポくださいです。Yes. Contrast,
Because
please.
calcium's over here.
Yeah, calcium on
Yeah, calcium.
the right side of the
Calcium
patient, left side on the screen.
Cap.
Yeah, agreed.
So when we have these long occlusions, we usually don't care whether we are in the lumen or extra lumina, but important is then to avoid stents.
じゃあ、柔らかいロングワイヤーください。トラッカーでもいいです。
Can you do injections through the lumen of the balloon?
I think what he's trying to do, but could you pull that balloon back just a hair
クルーズ
beyond
で
the
もやって
periosteum?
るがないんですよ
I。think you're in the side branch there.
Yeah.
You may not get a lot of bleed
so
back
it's
either
a little
because
constant,
the sheath is sitting in that CTO as well. So there's no
もう一
antegrade flow
回
yet.
エコー当ててみてくれる？はい。ハッシー、不潔でもいいよ。はい、ちょっとOkay. I'll exchange the wire to the soft one.
Contrast injection
No.
through the balloon?
I'd like to change the wire first, and I'd like to change this part from the...
It doesn't look like that's in the geniculate location yet, right? It's got to be some form of collateral to the geniculates.
Yeah.
But it's a medial path that is, oftentimes is the less resistant path.
Yeah, extra. Yeah. It's not
Yeah.
true lumen, I think. Yes.
It's extra luminal.
Yes. Maybe. Yeah.
Oh, now you're.
Yeah,
No.
it's
No.
subintimal root, yes. じゃあどうしようか。アイバスガイドにしますか。I'll change to the procedure to the アイバスガイド。アイバス出てる
Can we just see, would it be possible to do an angiogram from the sheath above? Unless it's really far down there?
Yeah.
Just to see what this thing looks like. Because the popliteal segment at P1 was open. There was a lot of disease there. But it was an open artery. He had a lot of diffuse disease below the CTO reconstitution.
Yeah.
It reconstituted with the, the profundocollateral on the lateral side.
Yes, yes, yes. I think so, but so please pull out the.
It's in a different
But in
spot now.
this, I use the guide caster, so I cannot use the contrast from the
I see.
Cs. So
There's still
I like to
calcium
check
on the
the
left side of the
IVUS.
screen.
It looks like it's going extra here.
Yeah.
Correct.
You need to point to 7, and it's pointing at 6 o'clock right now.
Yes, I think so. So I like to change the procedure to the IVUS guide wiring.
I would do an angiogram here, either
Yeah,
selectively or.
I want to do, but I cannot. Yes, because the guide sees. I use the 6-strands guide capture in the 6-strands guide teeth, so I cannot use the contrast.
We do all these procedures with 4 French nowadays.
For French.
That has reduced the bleeding complications a lot.
Yeah. That's good, I think.
I haven't been that bold to go to 4 French yet.
Huh?
I haven't been that bold to go to 4 French yet.
It's much better.
I can only imagine. I
Patient
think
can
it's-
go how much?
Okay, so give me the cross lead. Can you see the IVUS image?
Yes, we can.
Yes. The IVUS go to the subintimal lumen. So 좀 더 밀실까요? 곱창이요. 그래서 IVUS가 보이나요?
Where is your IVUS now? Proximal or distal in the lesion? Where did you start?
Just on the freezer shot there.
In other words, where is this image? Oh, it's downstream. It's okay.
Okay. Just the distal part, the cap.
We have 2 lectures to go through. If you want to get this started in the next 2 minutes, I'm going to start the first lecture, and then we can come back at the end of the session to see how you're getting along.
Okay.
Is that okay?
Okay.
All right, why don't you start your, whoops.
Good afternoon, everyone. I'm Sho Takagi from Toyohashi Center, Department of Cardiovascular Surgery, Japan. I would like to talk about TEVAR for thoracic aortic aneurysm using a Narita thoracic stent graft made in Japan. I have no conflict of interest to disclose with respect to this presentation. Introduction. TEVAR has emerged as a suitable alternative to open repair for thoracic aortic disease, especially in cases open surgeries are considered high risk. In case of descending aortic aneurysm, TEVAR are superior to open surgery in early mortality rate, the incidence of complications, including spinal cord ischemia, and length of hospital stay. This graph shows surgery for unruptured descending aortic aneurysm in Japan from 2007 to 2020. After the start of TEVAR, as TEVAR increases, open surgery decreases, but about 300 cases are performed annually. Open surgery is suitable indication in infectious aneurysm and compression syndrome due to aneurysm even now. According to Japanese guideline on diagnosis and treatment of aortic aneurysm and aortic dissection, TEVAR is recommended for descending aortic aneurysm if anatomical findings are suitable. In almost cases of descending aneurysm, there are enough landing zone in proximal and distal aorta the number of open surgery cases is less than that of TEVAR. TEVAR in the straight area of descending aorta resulted in the little end. We think the important point of TEVAR as follows. First, low profile. Low profile device contributes to reduction of access trouble. Second, less stress on the thoracic aorta. Oversizing of stent graft and strong radial force occurs to retrograde type A aortic dissection. In Japan, several thoracic stent grafts can use. I think it is important to use suitable stent graft differently depending on the shape and location of aneurysm. Variant and relay have spring-back force, but Zenith, TAG, and Naita don't have. Especially Naita stent graft is low radial force and PTFE graft on two stent. I think it is gentle to the aorta. The slide shows aorta diameter of deliveries. The Naita is smaller diameter than C-tag, variant, and relay. This slide shows good point of treatment selection using the Naita. The Naita is relatively smaller diameter and short and flexible tip. The precap that can be selected from 4 types based on patient CT. A structure in which a PTFE graft is sutured onto a stainless metal skeleton. Since the middle part of the graft is not sutured, the graft expands by receiving blood flow after implantation, like a AFX2 EVA device. It is gentle to the aorta. Naita thoracic stent graft is semi-order system with a combination of graft and metallic stent. There are only 2 sutured parts at the top and bottom. Penetration applies only to spec for arch. Naita have as many as 1,590 types of specification and select most appropriate one based on patient CT data. So it is not full customer made. In the process of preparing the Naita stent graft, the edited model was used for producing a physical plaster model in a 3D printer. This photograph is today's our case. A customized full-scale stent graft model was deployed to the plaster model before today's TEVAR. This report is perioperative and mid-term outcome of the Naita. All patients used fenestrated Naita for arch aneurysm. The rate of freedom from secondary intervention and rate of freedom from aneurysm enlargement at 3 years were 84% and 85%. The perioperative and 3 years outcomes of TEVAR using the Naita stent grafts demonstrated high freedom from aneurysm enlargement and patency rate of supraaortic branches. In concluding my lecture, TEVAR for thoracic aortic aneurysm using a Naita thoracic stent graft is a safe and effective as well as other thoracic stent graft. The Naita thoracic stent graft may be gentle to the aorta and have less occurrence of aorta. Thank you so much for taking the time to join today.
Thank you. Next is going to be a recorded session with Hirano Sensei. Can we roll the next talk, please?
Okay. Go up to
12先生
まず6。
はい。4
Talk number 2 from Sensei Hirano.
Looks like they are in the correct lumen now.
There you go.
I'm Keisuke Hirano from Toyohashi Center, and today I'm talking about the interluminal angioplasty and the robot supporting endovascular treatment for SFA CTO lesion. Here is my disclosure. This is today's agenda. Firstly, I'm going to talk about the evidence of interluminal angioplasty. Next, I'd like to talk about EVIS-guided baronial stent implantation for femoral popliteal CTO lesion. This paper was published in 2020 by Dr. Murray, and he enrolled 72 long SFA CTO lesion and performed EVIS-guide wiring procedure for femoral popliteal CTO lesion. The most interesting point in this paper, achieving a higher proportion of interluminal root improved the primary patency, as the restenosis rate was only 9% during the follow-up period, when a whole interluminal root was achieved. In this slide, the blue line shows whole interplug root cases primary patency rate, and the 2 years primary patency shows 86%. This slide shows multivariate analysis of restenosis, and the multivariate logistic analysis revealed that longer subintimal root proportion was a predictor of restenosis. Next, I'd like to talk about the drug-coated balloon for femoral popliteal CTO lesions. This paper was published in this year, and this paper describes IVUS-guided interluminal angioplasty versus subintimal DCB for the treatment of femoral popliteal CTO lesion. And 1 year freedom from restenosis rate was significantly higher in the interluminal angioplasty. And next, I'd like to talk about the EVIS-guided DES for femoral popliteal CTO lesions. We don't have any DES stenting interluminal angioplasties paper yet, so I'd like to show you our hospital's data. We enrolled 44 long SFA CTO lesion and performed EVIS-guide wiring procedure. The 2 years primary patency rate shows 90%, and the freedom from TLL shows 100%. Therefore, in 2020, we started a prospective study, the EPOCH study. And this study is EVIS-guided interluminal DES stenting for femoral popliteal chronic total occlusion lesion. And currently, 62 patients have been enrolled, and the 2 years primary patency rate was 100%. Next, I'd like to talk about the EVIS-guided interluminal angioplasty. This paper was published in 2020 by Dr. Tokuda, and this paper comparison of EVIS-guided versus angiography-guided and vascular treatment for SFA CTO lesion. This procedure was always performed with long axial view, and sometimes we could check the wire position from the short axial view, so it is easy to get the interluminal root to perform the EVIS-guide and vascular treatment. In the EVIS-guided group had significantly lower radiation time, radiation exposure, and amount of contrast than the angiography-guided group. And the procedure time was significantly shorter than the angiography-guided group. So I think in the EVIS-guided procedure, we could perform interluminal wiring in a short amount of time, and the EVIS guide is also less invasive. EVA's guided procedure looks good, but it had a problem. So next, I'm going to talk about the problem of the EVA's guided endovascular treatment. I have been performing EVA's guided endovascular treatment for 20 years since 2004, but it had a big problem. There is no technician or doctor who can perform EVAs, and there is not enough manpower. This is the biggest problem in the cath lab. So I think one of the solutions for this major problem is EVA's supporting robot. So we developed the robot, and this medical device developed by Asahi Intech, Fuji Corporation, and me. Next, I'll show you what does it actually look like. This is the EVA supporting robot Watson, and the robot mainly takes the place of echo technicians, and it grabs the echo probe and detects the CTO artery. This medical device obtained the government approval on 2021, September 6. And we started clinical use of EVA supporting robot from October 2021. Next, I'd like to show you the features of EVA supporting robot. This slide shows the features of EVA supporting robot. And the most important thing is that even inexperienced person can determine high quality images. Next, I'll show you returning the probe to a previous position from short to long axial view. This procedure is difficult for a technician, but easy for robots. Finally, I'll show you a case presentation of EVA supporting robot. This case had a long femoral popliteal occluded lesion just proximal side to distal part of the SFA. I performed the EVA's guided robot procedure like this, and I controlled the robot by myself and performed the interluminal wiring. And this is the final result. In conclusion, I think the EVA's guided wiring is the best procedure to perform the interluminal angioplasty and improve the chronic outcomes. Thank you for your attention.
All right, that was some great presentations. Do you want to go back to the lab and see how they're getting along? Hirano Sensei, you're back on camera. If you want to give us an update, we have a couple minutes for you.
Okay. The distal part of the SFA is the weak point of for the EVA's guide wiring because the vessels CTOs goes deeper, and so the ultrasound cannot reach to the artery. So in this situation, I always change to the EVA's guide procedure, and I perform the EVA's guide procedure. And Can you see the IVAS? IVAS 画面を大きくしてください。
We had the IVAS. It's in. There's a main IVAS now. Yes.
メインを IVAS に。Okay, and this is the IVAS after passing the wire. This is a popliteal artery and pull, and that is the subintimal space to. I'll get the re-entry to the intimal lumen. で、造影を見せてもらっていいですか？このワイヤーの跡かな？ Okay, this is the after ballooning angiography. I selected 5 by 300 millimeters. Yes. How do you think? What do you think?
I think you got into the true lumen for sure. It still proves the point that there's still a lot of plaque when you dilate proximally. There's a lot of dissections. I mean, those are type C dissections
Yes.
proximally. So are you, so I guess two things in the time you have, which are basically about a minute. Are you going to treat the entirety of the popliteal segment to the trifurcation with DCB? And then are you going to stent more proximally? What's your plan for the entirety of the lesion?
Thank you. I like to use the DCB for Hiroyoshi for the popliteal lesion and SFA CDO. I got the type C dissection, so I like to implant the Luvia DES for this part. Yes.
Anybody else? I know that Horst, you would not stent the dissections?
No, we would use a DEB with a long inflation. I would inflate the balloon, go for
Long
a coffee, and
inflation.
come back
Okay.
20 minutes later, and then
Okay.
it usually looks nice.
Looks better, yeah.
Thank you very much.
Hirano sensei, I am Yokoi.
Hi.
Thank you very much. Very
ありがとうござい
excellent
ます。
technique, very interesting, the EVAS guided.
Thank you very
I
much.
asked to you one question.
Okay.
This system, the long axis and then the short axis, two different view you can get. But today's your procedure only long axis.
Yeah.
Long axis and short axis combination more easy to get the intraluminal. How do you think that?
Yeah, that's right. But in the probe, put the thickest point of the vessel, and you can see the wire in the image. That means the center of the vessel. So in that situation, I'm not check the short axial view. Yes. So.
Actually, I was wondering why the machine cannot do X-plane. I mean, this is not an intravessel thing. I mean, the transcutaneous ultrasound probe should be able to provide X-plane. So then you can see long axis and short axis at the same time.
At just the same time?
Yeah, I mean, the percutaneous ultrasound should be able to do that.
Yeah. But today's ultrasound cannot get the short axial view and long axial view at the same time. So, yeah, we turned.
You have to
and
turn,
use
yeah.
the both,
I saw
yes.
that, yeah.
All right. And you don't know what stent you're going to implant proximally yet? You're going to go with the DES. Is it going to be Illuvia, or do you think you'll do
Yes.
Silver?
Illuvia for the proximal site,
Understood.
CTO SFA proximal site, and DCP for the popliteal artery.
Understood. Well, I think we have run out of time. So, Sensei, I think that you've done a fantastic job. Two very interesting cases from your center. Thank you for your time, and thank you for a great case. For my
Thank you very
co-moderator, Dr. Sievert, and for all our panelists, I want to thank you for your time, Sensei.
Okay.
Thank you, guys.
Thank you very much. I would like to say thanks to the chairman and the commentators. Thank you very much. See you next year.
Thank
Bye-bye.
you. Enjoy your day at TCTAP, guys.